What's up, everybody? Dr. Bonzo back again. You know I'm looking pretty spiffy today. Just finished speaking at the License to Live conference and figured while I was so dressed up, I would hit you with another quick-hitting, high-yield review of a medical topic in 5 minutes or less. Now, last week, we talked about short-acting birth control. We talked about the combined hormone contraceptive methods that contain estrogen and progesterone. And we talked about 3 of them. We talked about pills that you take every day, the patch that you apply once a week, and the vaginal ring that you insert once a month. They all work the same way. They inhibit ovulation and also thicken cervical mucus, so it's hard for sperm to get inside. And they have the same contraindications, in other words, the same reasons you would not use them. We never use those combined hormone short-acting methods with estrogen in them if you have any history of clotting of any kind or a hypercoagulable state like antiphospholipid syndrome. We don't use them in smokers over age 35, and we don't use them in women who have migraine headaches with aura. All those women will have an increased clot risk if you give them estrogen. In terms of postpartum women or women who just had a baby, never use these methods in the first 3 weeks after they delivered because of the increased clot risk, and don't use them typically in the first 6 months after delivery if they're breastfeeding because the estrogen will interfere with prolactin's action and decrease your milk supply. So that's the summary of last week. Let's talk about this week's, which are our progesterone-only containing methods that are long-acting reversible contraception, LARC or LARC. Now these methods, because they don't have the estrogen in them, these methods can be used in women who are smokers or who have clotting risk. In fact, these are the preferred methods, so pay attention to these 3 methods we're going to talk about. There's the implant, the shot, and the IUD or intrauterine device. They all work the same way. They have lots of progesterone in them, and they thicken up that cervical mucus. So again, it's really difficult for sperm to get inside. If a sperm does make it inside, the progesterone interferes with the action of sperm's ability to fertilize an egg by interfering with some of the proteins. So it's hard for its fertilizing egg if it does make it through. Finally, these methods thin the endometrial lining or the lining of the uterus or the womb, which makes it very difficult for a fertilized egg to implant. So even if you get a super sperm that somehow makes it through that thick cervical mucus, somehow fertilize that egg, it's not going to be able to implant. Now that last mechanism of action is super important because of that thinning of the endometrium, most women who are on these methods will actually have light periods or no periods at all. Some of these methods are actually FDA approved for the treatment of abnormal uterine bleeding. So these are great methods for women who say they have heavy periods, painful periods, or really prolonged bleeding during menses. So let's talk about each individual method. So there's a shot that lasts every 3 months. It's known as Depo-provera. And so it's 150 milligrams of medroxyprogesterone. You come into your doctor's office every 3 months to receive the shot. Now, because it's a little bit higher dose than some of the other progesterone methods, it's sometimes a little bit higher risk for having that abnormal bleeding, and it also increases women's appetite quite a bit. So it causes a little bit more weight gain than the other methods. For that reason, I usually tell women if you can't afford to gain about 9 pounds or so, don't take Depo-provera. Depo-provera shots also have a black box warning for osteoporosis because it decreases bone mineral density, so not a great method, for example, women who have the female athlete triad. Now, the one nice thing about Depo-provera is that for whatever reason, it decreases painful vaso-occulsive crises in women who have sickle cell disease. So not sure the mechanism of action, but it does it pretty well. You'll notice that some women who have sickle cell disease, even if they have their tubes tied, they still get their Depo shots to take advantage of this effect. Now the next thing to talk about is the implant, commonly known as the Nexplanon implant. It's an etonogestrel progesterone, and its claim to fame is really decreasing painful periods. So in one study, women who have dysmenorrhea or painful periods, when they got the Nexplanon implant, had about an 80% decrease in their painful periods. Now, the last method is the IUD or intrauterine device. There's 4 different kinds on the market. They're pretty much the same hormone, levonorgestrel. The only difference between them is pretty much the the amount of progesterone that's in them and how long they last. Mirena is the most common one. It has the highest dose of progesterone. It lasts for 5 years. Liletta is the same exact thing as the Mirena. It's pretty much a generic. It actually has an FDA approval for 6 years. And between you and me, the Mirena and the Liletta IUD both last for 7 years. There's plenty of studies that show that. There's also one called Kyleena, which is kind of middle-of-the-road hormone level. It also lasts for 5 years, but is a lot lower hormone dose for women who don't like a lot of hormones. And finally, there's one called Skyla, which is the lowest dose. It lasts for 3 years. Be careful for women who have active STDs. If a woman gets PID while she has an IUD, it's going to be a lot worse. So if anybody has an IUD and has an STD, make sure you treat it at the time of the IUD insertion. All right, there you go, a review of LARC in 5 minutes or less.